Here's an example of an acute myeloid leukemia, and on the feathered edge we can see that there are numerous mononucleated cells. This already should raise your red flags for an acute leukemia. As we find our zonal morphology and go to higher power, we see that the large mononuclear cells have smooth chromatin with prominent nucleoli and a thin rim of cytoplasm. When starting out, it may be difficult to identify blasts due to the paucity of blasts seen in the peripheral blood smear and even in the bone marrow, especially with hemodilute samples. A good way to identify a blast or an immature cell is to see these prominent nucleoli. In addition to nucleoli, you really do want to see a smooth chromatin pattern, and without a physical cell in front of you, it's difficult to describe the chromatin as smooth and to understand that concept. So I like to think of it as sort of appearing like a fine sand. So if I took my rake and I tried to drag it through a fine sand, I wouldn't hit any lumps or bumps, and it would be smooth for me to drag that rake through this cytoplasm. In contrast, if we find a mature appearing cell, such as this neutrophil, we can see that this chromatin is very clumpy, and if I tried to take my rake through this, I would certainly hit lots of bumps along the way. If you find that the blasts are granulated with more abundant cytoplasm, you may be more suspicious that this is an acute myeloid leukemia as opposed to acute lymphoblastic leukemia. Additionally, if you see our rod inclusions, you may definitively call this a myeloid lineage cell. Here's another good example of an our rod inclusion, confirming our suspicion that this is likely an acute myeloid leukemia. Acute leukemias are characterized by an increased number of blasts in the bone marrow and or peripheral blood. To make a diagnosis of an acute leukemia, there must be greater than 20% blasts in the peripheral blood or bone marrow. Occasionally, the peripheral blood may show no circulating blasts or only a few circulating blasts. The white cell count may also be increased, normal, or even decreased. So in this case, with greater than 20% blasts and inclusions of our rods, we can definitively call this an acute myeloid leukemia. However, we will also want to better characterize this blast population based upon immunophenotyping, cytogenetic findings, molecular techniques, and or special cytochemical and immunohistochemical stains. Acute myeloid leukemia is classified into 4 groups: acute myeloid leukemia with recurrent genetic abnormalities, acute myeloid leukemia with multilineage dysplasia, acute myeloid leukemia that is therapy-related, and acute myeloid leukemia not otherwise categorized. Here we see an example of a blast with characteristic cup-shaped or fish mouth morphology. These buzzwords are used when pathologists know that there's a recurrent genetic abnormality, including NPM1 or FLT3. Of course, we wouldn't assume that this cell had that abnormality without doing the ancillary testing required to make those diagnoses. Here's another example of a cup-shaped blast or fish mouth blast, where you see a sort of indentation on one side of the nucleus. And here's an example at 50x where we can see there are numerous eosinophils in this patient who also has greater than 20% blasts in the bone marrow. This eosinophilia could suggest to you an acute myeloid leukemia with either inversion 16, translocation 1616, or a mutation in PDGFRA and PDGFRB, sometimes referred to as core binding factor related leukemias. If blasts show characteristic blebbing as seen in these 3 blasts, this may suggest a megakaryoblast lineage and can be seen with acute myeloid leukemias with translocation 122. This type of AML occurs most commonly in infants without trisomy 21. Myeloid proliferations associated with Down syndrome, such as transient abnormal myelopoiesis associated with Down syndrome, or TAM, is a unique disorder of newborns with Down syndrome and presents with clinical and morphologic findings indistinguishable from those of acute myeloid leukemia. Typically, these blasts have morphologic and immunological features of megakaryocytic lineage. In addition to these patients having trisomy 21, acquired GATA1 mutations are present in the blast cells of transient abnormal myelopoiesis of associated with Down syndrome. This disorder is characterized by a high rate of spontaneous remission. However, a non-transient acute myeloid leukemia develops 1 to 3 years later in about 20 to 30% of these children.